My name is Hongju Park from Asan Medical Center. This program is hosted by 3 universities, which are University of California, Irvine, Hamburg University, and Asan Medical Center in Seoul, Korea. So I hope that this program can be a platform for sharing the clinical knowledge in ENT field. Today, I'm going to talk about the prediction of cochlear implant performance, especially concentrating on the cortical reorganization by auditory deprivation and also the restoration of the cortical changes by hearing restoration using cochlear implant. I'm going to talk about the prediction of model using machine learning in the beginning, and also the importance of cochlear nerve and shape and tail sign in MRI. And also, though, I'm going to see about the changes of auditory and associated cortical volumes by deafness, and also their effect on cochlear implant performance. And finally, I'm going to talk about the restoration of the auditory cortical volumes by hearing rehabilitation using cochlear implant. First of all, we all know that the cochlear implant is a treatment choice for hearing loss, which is severe and profound hearing loss, which is not useful for hearing perception, even though using the hearing aid. So the performance of cochlear implant can be influenced by the many factors, including the age and duration of deafness and presence of residual hearing, also the previous hearing aid use, and also the absence of cochlear anomalies. But there are some controversies about the duration of deafness. Most studies show that the negative relationship with post-operative speech. However, there are some reports about the positive relationship with speech recognition, and also that there are some controversies regarding the age SCI. So most papers show that the younger patient have a better result than in old adults, but there are some reports showing the no differences between middle-aged and eldest patient. So let me start with the case with a 53-year-old man with bilateral hearing loss. He came to my office complaining of bilateral sensory neural hearing loss. Right side had a sudden hearing loss 3 years ago and nearly deaf here. And on the left side, there was a sudden hearing loss about 1 month ago, and the hearing threshold was around 60 decibel, but the discrimination was pretty poor, or around 24% at the stimulation at the level of 88 decibel dBHL. So which means that he cannot communicate well even using the hearing aid. So we decided to do cochlear implant surgeries on the right side, because that the right side has a history of hearing loss for more than 3 years. So there is no possibility of hearing recovery. So I did a cochlear implant on the right side, and there was a post-operative 1 week. The word recognition score was around 76%, and 1 year around 88, and 2 year word recognition score was 92%. So which was very successful result. But the problem is that the performance of cochlear implant is not always good. For example, this patient is 52 years old, and this is our result from the 120 patient. So this x-axis means that the age SCI, and y-axis means post-CI 2-year world recognition scores. So for example, if a patient is around 50-year-old, and there are many people at around with the age of around 50, but the result is quite variable. So there are huge individual variations. For this patient, it was around 92%. It's pretty good, but no, it's not always true. Some patients can have the post-operative world recognition scores less than 10%. So if a patient give me a question about the predicted post-CI result, I can say that generally good, but I'm not sure. So that's why I want to make a prediction model and which factor is important. So I can communicate with the patient with the possible and realistic expectations. So we collected 120 patients with no inner ear anomalies and or other disabilities, and the result was we only recruited patients with a follow-up for more than 2 years. And main outcome was the score of open-set monosyllable or the recognition score in quiet situations. And we used the prediction model of the general linear model, which has been used for several years. And we also used the machine learning new model, which is a random forest regression models. And we used many factors: duration of deafness, age SCI, and duration of hearing aid before the cochlear implant, and also the preoperative Pearson average, ipsilateral to the contralateral side, and also the sentence recognition scores. And this is the result. So generally, the random forest regression model could predict more precisely compared to the general linear models. This, for example, this is x-axis means predicted word recognition score, and y-axis is true word recognition scores post-CI. And this is using the general linear model. The mean absolute error was 15%, which is quite a lot. But when we use the random forest regression model, the mean absolute error was only 6%, which is more precise compared to the general linear models. So, but this model is a machine learning model, so we cannot predict and we cannot know which factors are important. So we omitted one factor and then recalculate the prediction model. And then if we see the difference between the prediction power before omitting one factor or after omitting one factor, we can see that factor, how that factor is important. So when we omitted duration of deafness, there was a huge difference of the prediction powers, which means that the deaf duration was the most important factor. The difference of the mean absolute error was 15%. So duration of deafness was the most important factor. And second one was the age SCI, which means that the age was pretty important. And third one was the duration of a hearing aid before cochlear implant. So these three factors were the most important factors, although there are other factors it can influence on the result, but these three factors was most important. So we wanted to see how the three factors are important in prediction of the post-CI result. So this is the result. So we think that we know that the duration of deafness was the most important one. So we divided 10 years. So when we collect the patient with the duration of deafness less than 10 years, and this is the age-SCI, the second most important factor. So y-axis means the age-SCI and y-axis, and y-axis means post-CI performance. So when we look at the data, when the patient was around 20 years old, which means that, for example, the sudden hearing loss occurred at 20, and then if the patient get the CI 1 or 2 years or even 5 years later, the result was pretty good, around 90%. But when the patient have a duration of deafness less than 10 years, and the age-SCI was around the 70s, the result, post-CI result was around 60 or 70%, which means that the age-SCI was important also, and also the deaf duration is important. But when you see the patient with the deaf duration of more than 10 years, for example, here, a green dot means that the duration of deafness is between the 10 and 20 years. The result was pretty good, a little bit less than the patient with the deaf duration of less than 10 years. But generally, they are good, around 10% below the patient with the deaf duration of less than 10 years. But there are some outliers. But when we look at the patient with the deaf duration of more than 20 years, the age-SCI was not important because there were large individual variations. So which means that if we see the patient with less than deaf duration of less than 10 years, we can tell the patient the result would be pretty good without very few exceptions. And if we see the patient with the deaf duration of 10 to 20 years, mostly generally good with a little bit of few and exceptions. But when the deaf duration is more than 20 years, it's hard to tell the post-CI result. And we need another factors to determine which will be the best or not. So that's why we focused on the more central region, for example, cochlear nerve itself, and also the cochlear auditory cortex or associated auditory cortices. So first of all, we focused on the cochlear nerve that diameter and shape. So we collected 87 postlingual deaf adults with 2-year follow-up audiological evaluations, and we used the temporal bone MR to evaluate the cochlear nerve. And when you look at the cochlear nerve, this is a sagittal section, and you can see that the very fine characteristics of the cochlear nerve. So when you look at the cochlear nerve, this is the basal tone and mid-tone and apical tone. So because the MRI have a very fine, high resolution, you can see that all the fibers of the cochlear nerve, just like a cochlea. But in this patient, the middle and apical tone diameter is a little bit short, smaller, and we cannot see the high frequency hearing phase cochlear nerve, which means that this patient have a lack of cochlear nerve at the basal tone region, and this patient very small diameter without any fibers in basal tone areas. As we all know that the cochlear hearing aid are not helpful for the cochlear dead region because there is no inner hair cells. So same thing can happen in cochlear implant. If there is no fibers at basal tone region, there will be nothing if you even though you put the cochlear implant, because there are no cochlear nerve. So I think that the diameter of the cochlear nerve is also important, but also that the shape and especially the fibers of from the basal tone is pretty important. So that's why we use the you use that uh, 98 patient, and this axis means that the diameter of the cochlear nerve, and y-axis a monosyllable post-CI work direction scores. When you look at the data, there is a positive correlation with the nerve diameter and post-CI performance. So if the cochlear nerve diameter is large, which means that the better post-CI result. But when you look at this one's a blank one and a dark field rounds also means that field rounds means a tail sign positive, which means that there are positive cochlear nerve from the basal tone. When when you see the blank round, this you cannot see the tail sign. So when you see the blank round here, generally most of them show the pretty poor result, which means that when the diameter is small and the tail sign is negative, and then the post-operative result is not good. So we can help the patient about the prediction of the cochlear performance before the surgery, and we can give the patient the realistic expectations, which means pretty good because that the patient should prepare for the post-operative cochlear implant performance. And next one, we also think that the brain cortical changes also can influence on the post-CI result. Brain cortical changes can be the result of the deafness, and in the reverse, the cochlear brain cortical changes can influence on the post-CI result. So we wanted to what could happen after deafness. So we recruited patient with a sudden hearing loss, and also we recruited from the patient for CI with the long-standing bilateral deafness. So we compare those two groups and see what happens between the two groups. Before we see the result, we should know that the superior temporal gyrus, there are primary auditory cortex in this region, and also the middle temporal cortical was important because that the damage of these regions would impair the learning of the English language. So which means that the middle temporal lobe is pretty important in learning the English language. And we used also the machine learning technique to see the difference and prediction procedures. And we use the coronal T1 weighted imaging, and we use the voxel-based morphometry to see the gray matter probability, which means we're presenting the gray matter volume. And we compared gray matter volumes between the sudden hearing loss versus bilateral postlingual deafness patient. And also we correlated the volume and depth durations. And this is the result. So gray in patient with bilateral deafness, there are lots of areas with the brain atrophy, which means that we can understand that because that there is no auditory input from the ears, the brain does not work properly, and then many areas of the brain show that the brain atrophy. So, and the most important region was bilateral superior, middle, and inferior temporal cortices, and also primary motor and primary somatosensory cortices. and thalamus, these areas. And interestingly, so when you look at this area, motor and sensory area, this area was related to the lower face, tongue, and throat. So we can easily understand these findings because that when the deafness is persistent, and then there's no social communication, and there's no use of the tongue, and because we do not communicate to each other, so that's why we can understand that the brain atrophy, regarding the tongue and throat in this patient. And we also wanted to see that how the brain changes as a function of depth durations. So, but we saw that in the beginning we thought that because that there is no auditory input, the most brain cortex should shrink as a function of depth duration. So, but it was not true in always. For example, here, this is a superior temporal cortex, which is including the primary auditory cortex. In the beginning, the superior temporal gyrus show the brain atrophy in the beginning of the deafness. However, the volume gradually increased, and after 30 years, the volume, recovered to the normal range, and then even the increased, which means that this area, the superior temporal cortex, is changes, but it changes in decades, not years, which means that in the long-term changes can happen. And initially, the brain atrophy occurred. However, in the long run, the volume recovered even after 30 years. So which means that the primary auditory cortex is used by other sensory cortex, which is we call that the cortical reorganization. However, when you look at the middle temporal gyrus, this area continued to decrease as a function of depth duration, which means that the middle temporal cortex is not used by other systems, and only this area is used by the auditory system, and this cortex represented the duration of deafness. And we all know that this kind of cortical reorganization can happen in patient. For example, here, this is a visual evoked potential. So when a patient lose hearing loss suddenly, and then the visual stimulation only stimulate the occipital lobe. However, even after 3 months after hearing loss, the temporal cortex start to respond to the visual stimuli, which means that the primary auditory cortex respond to the visual input. And this can happen even after 1 year and prolonged. So this means that the primary auditory cortical area is used by the visual system when there is no sound input to these areas. So that's why the superior temporal gyrus initially decreased, but gradually over 30 years recovered. And we also used that or wanted to use these findings to predict the post-CI result, and we could find the 3 different areas, but it worked differently. For example, middle temporal gyrus, if the volume of the middle temporal gyrus is important, and when the volume is pretty big, which means that the recent hearing loss, the post-operative result is pretty good. However, the superior temporal gyrus showed a different, reverse reactions. And we use a heat map because there are quite different areas. So individual patterns show a poor or good outcomes could be explained not solely by the specific feature, but by the combination of multiple features. For example, this is a word recognition scores, and worse means that the smaller scores show the blue one, high score means yellow one. For example, middle, if the duration of deafness, is shorter, the better result. And HSCI, also the younger patient show the good post-CI performance. For example, here, but when you look at the this area, this one, middle temporal cortex, usually when the middle temporal cortex is pretty big, which means that it's a pretty short depth duration, pretty good result. But even though middle temporal cortex is small, but the HCI is young and depth duration is short, and that you can expect a more pretty good result. So in this way, there is this kind of combination of multiple features can determine the cochlear implant. And finally, we saw that this kind of brain atrophy could happen by the deafness. And we wanted to know that if we put a cochlear implant and we get a hearing restoration, we wanted to see the restoration of the brain cortical atrophy. And we wanted to at which area this kind of restoration could happen after cochlear implant. So we used nowadays the a series of the cochlear implant can we can check the MRI because they are MRI compatible. So we get the post-operative MRI after 1 year after CI surgeries. But the problem is that the CI resulted in the artifact in the area. So we removed this area, and then we replaced it with the pre-operative MRI, and then we analyzed only the contralateral side, because that the auditory input goes to the contralateral area, primary auditory cortex mostly. So we think that it's enough. So we only analyzed contralateral side. So we collected the patient with the bilateral deafness and who underwent only one side cochlear implant. Nowadays, most patients underwent a bilateral cochlear implant, but because our national insurance only support one side cochlear implant, the other side should be done by the patient own expenses. So some patients could underwent bilateral, but others only could manage to get one side cochlear implant. So we recruited those patients and we get the MRI after 1 year after surgery, and then we analyzed it, and we saw that the many areas there was a substantial increase of the brain cortexes, especially in supratemporal gyrus. And we could see that also that when the restoration is large, we could expect better post-CI result, which means that which can be understandable because that the primary auditory cortex is a direct input from the cochlea, and then this is first input area can show the reverse of the restoration of the cochlear implant. So to my knowledge, this is the first study to show that the brain cortical restoration by the hearing rehabilitation using cochlear implant. In summary, the post-lingual deaf patient usually get pretty good post-CI performance, and short duration of deafness important, and younger age CI operation was also important. So we should recommend the patient with a bilateral deafness as early as possible. And when the patient is hesitating to get the surgery, and then we should recommend the hearing aid before getting the cochlear implant. And we also could see that the gray matter volume of the cochlear implant group showed a decrease in various regions, including the auditory and language areas, as well as thalamus and focal areas of motor sensory functional areas. And we also that the prediction of cochlear implant can be performed using the many clinical features and also the image features, and also the cochlear nerve diameter and also the shape of the cochlear nerve was important, and we could get help in predicting the post-CI performance just by seeing the shape and diameter of the cochlear nerve. And also the decreased supratemporal gyrus could be reversed by cochlear implant, and this recovery was correlated to the recovery of the speech perception abilities. So this is what I prepared for this meeting, and I think that this kind of clinical knowledge can be helpful in predicting the post-CI result and in counseling with the patient who want to get a cochlear implant for the hearing restoration. Thank you for your attention.